Okay, that rounds out the food portion. Now we're going to talk a little bit about insulin management. So you do something to manage your meal plan that most people are not familiar with. Most people, when they're diagnosed, are given rapid-acting insulin and huge amounts of carbohydrate food suggestions from their dietitians. And so when they read your book or they talk to someone following your plan, they've never even heard of what we call an R, or regular insulin. So can you talk about the importance of using R in your meal plan and in your plan to get normal blood sugars?
Okay. Type 1 diabetics, for the most part, at least in the USA, are using basal bolus insulin regimens. This means that they have a long-acting insulin that they take twice a day to cover the fasting state. If they're not eating, they still need a little bit of insulin all day long, and that's the basal insulin. To cover the glucose that comes in from meals, they need rapid-acting insulin. And there are several different classes of rapid-acting insulin with different action profiles. The slowest of these is regular insulin, which is true human insulin that's diluted 25-fold. And it starts typically, for the average person, it starts working about 40 minutes after an injection and continues working for 8 to 10 hours. But most of its action is during the first 4 or 5 hours. Now, if you're on a low-carbohydrate diet, this is just the timing you need for your insulin. You're matching the digestion of the carbohydrate and protein that you're eating. If you're on a very high carbohydrate diet, as the professional diabetes associations and endocrine associations recommend, then the logical thing is to take a faster-acting insulin. The faster-acting insulins are called Novolog and Humulin, and there's another that's sort of a little bit slower than those called Apidra. Now, in theory, these would work great, but the trouble is that these insulins have a sharp peak, and high carbohydrate foods, rapid-acting carbohydrates, have a sharp peak. And you're expected to match those two peaks in time. A near impossibility. Using the term near is even exaggerating, because it's a true impossibility, because the people who do this never match. They always go too high or too low after meals, and then may go too high or too low later on.
Right.
So it's impossible to make this kind of match where you're trying to take two peaks and match them.
Right.
What we're doing with regular insulin, low carbohydrate and protein, is taking a shallow hill,
Yes.
2 shallow hills like this, and attempting to match them. And if you're a little bit off, you're not going to make a huge mistake. So your timing may be a little off, but you get, if it's off today, tomorrow you can adjust it by 5 minutes or so, and that might put you right on, because you're just matching up 2 shallow hills.
It's a very physics-based argument you're making. So even if these parents, I see a lot of discussion where a parent will be obsessed with a cupcake if it has 42 or 45 or 41 grams of carbohydrate, if only they could get the carb count correct. You're saying that carb counting doesn't work because of this analogy about these envelopes overlapping.
Right. You're dealing with mystical things when you think that being precise on counting carbohydrate is going to make up for the fact that you're trying to match a sharp peak with a sharp peak from insulin. It's not going to work. It's impossible.
Sometimes you'll go...
Here we have Here we have the insulin makers, the doctors, the dietitians, all pretending that the impossible not only is possible, but it's working every day. And that all these people with the rapidly varying blood sugars are well controlled.
Mm-hmm. Okay, so how do I use R? If I have, if I'm lucky enough to convince my endocrinologist to give me a prescription of R. By the way, R is available over the counter, right? And it's
in many states.
I think it's like $20 at Sam's Club. But how, suppose my kid eats a couple pieces of chicken and his meal plan. How do you use the R?
Well, it's first of all, in his meal plan, he's not just getting a couple of pieces of chicken. He's getting a weighed amount or a reproducible amount that he's getting every day, and he's getting a reproducible amount of carbohydrate that's kept relatively low, and we'll start off with a guess as to how much regular to use for this meal. Now, I have formulas that I use that are fine for people who don't have insulin resistance. And the formulas are simple. A half unit of R covers 1 ounce of protein. And 1 unit of R covers about 8 grams of carbohydrate. Just let me think for a minute. Yeah, 1 unit of R, in theory, covers 8 grams of carbo, and a half unit of R covers 1 ounce of protein. So when you're starting your meal plan, your initial guess could be by doing the computations that I just made, and then maybe lowering it by 20% to play it safe, to be on the safe side. Chances are it'll be too low, but you see what happens to the blood sugars. And then you can increase the R the next day for those meals, a half unit per meal or a unit per meal, based upon how much you know that 1 unit will raise your blood sugar. Well, how do you know that? With a very obese individual who's insulin resistant, or someone who's pregnant, or a woman who's having her period next week, it's really a guess as to how much 1 unit will lower blood sugar. But for a person who's not obese, for a kid who's not in the middle of a growth spurt, someone who weighs, let's say, 150 pounds, 1 unit of insulin will lower them about 40. That's an initial guess. So here, after this meal, your blood sugar is running 40 higher than you would like it to be. The next time for that meal, you add 1 unit to the insulin. If you're running 20 higher, you add a half unit, etc. So it's plain and simple. The math is not complicated. Doctors don't want to even learn this. It's much easier to just take a lot of carbohydrate, a fast-acting insulin, and then close your eyes. And throw the patient out there to take care of himself, or give him to a nurse educator or a dietitian and let them worry about it. And if you've looked at dietitians, most dietitians are overweight. Many of them are very obese. And many of them are diabetic. And those who are diabetic are frequently taking large doses of insulin to cover all the carbohydrate they're eating.
My experience with my kid, I'm going to advertise what you're saying is correct. The experience is that we have his basals correct. He wakes up in the morning with normal blood sugars right around 80. he has his breakfast and he does his shot of R, and he goes to school, and now he has he'll test before lunch, maybe twice, and his line is flat all day until lunch. And then at lunch he does another dose. He eats a breakfast and lunch that he loves, so he's comfortable with the food, and then he's flat until he comes home. So he loves this because he wants to play at recess. He doesn't want to report to the nurse's office with a blood sugar of 400. He doesn't want to feel bad all day. He wants to live his life. So the regimen that you're describing it's not a set it and forget it. He still has to do a finger prick and make sure. But if he needs to correct himself, he might do a half a tab of glucose, which he keeps in his pocket, not sucking down juice boxes in a severe state of hypoglycemia. And if for some reason his blood sugar runs high, he takes a little bit of insulin and he's back to normal. It's a totally different way of living your life. It's like our life has been restored as a family.
And it's unfortunate that neither the medical profession nor paramedical professionals nor industry is really interested in the patient. Outcomes like this are of no interest.
Yeah.